So today, we're welcoming Dr. Roberta Goldman, professor of family medicine at Alpert Medical School here at Brown, and adjunct professor at Harvard T.H. Chan School of Public Health. She has a PhD in sociocultural anthropology from the University of Florida and has been actively conducting qualitative research projects for over 30 years. Dr. Goldman's work focuses on investigating issues of social context in community and primary care-based studies, health behavior interventions, and patient-centered outcome research. Her expertise is in community engagement for multi-method qualitative research with special foci on immigrant, minority, and non-English speaking populations, as well as populations with low income and low health literacy. She has conducted research across the age spectrum, and she is also co-director of the program in scholarly development in the Brown Family Medicine residency and teaches qualitative research for public health at Harvard. Today, we'll be discussing Dr. Goldman's paper, Patients' Reflections on Communication in the Second Opinion Hematology-Oncology consultation published in the journal Patient Education and Counseling. So welcome, Dr. Goldman.
Thank you. Thank you, Dr. Dubé. It's good to be here.
Okay, great. So let's talk a little bit about this study from this paper. So where did the idea come from to include qualitative research with this project?
Well, it's really interesting because the PI on the study is a, a bone marrow stem cell transplant surgeon. And that is not necessarily the kind of discipline you would think would be really into qualitative methods. But what she wanted to know was, what are the patients thinking? What are the patients experiencing? And how can we make it better? And she somehow realized that she had to include qualitative. Now, this was turned out to be a mixed method study with a lot of quantitative components, but the qualitative was a strong part of the study that that we ended up being able to publish this paper.
So this qualitative approach was able to pull out from patients a story that you couldn't get any other way. So
Yeah,
talk a little bit about that.
yeah. So I'll just go back for a second. And what the issue is that I guess when people go to a tertiary care center that has a large cancer division, then what they can do is get what's called a second opinion consult. And so they're not patients of these doctors. They're not continuity patients. They will not get treated by these doctors, but they travel far. We had patients who came from all over the United States and in other parts of the world, actually. Um, this was before COVID, so it wasn't telehealth. They were coming in person, but these are long, in-depth 2-hour visits that they get. And this is what the PI, Dr. Lee, was interested in: is, are patients getting what they need out of this consult? So we had many quantitative aspects that we included. So it's a true mixed method study. But those aspects are really interesting because we did, as an example, uh, pre-post consultation assessments. We had the physicians fill out surveys before and after about what they thought the prognosis was, what they thought was going on. Patients were called and asked what they thought their prognosis was and what their serious issues were. There was a whole series of steps that we had, but we realized that until you actually talk to the patients and let them in their own words tell you what they were thinking, um, it's not going to happen. So in this case, there were a couple of interesting things. That was a first for many. One was that we audio recorded 264 patient consults, so 2-hour patient consults. Actually got that done. The recorder got turned on, and we had access to those things. And so we ended up using some interesting quantitative, I don't even know what to call it, like audio software where we coded what they were doing in terms of not what people were saying, but where the hesitations were and where who was talking more and all of that. So you can only imagine it took us a year to set up that coding scheme because I wanted to know, what are they saying? Why are they saying? How are they saying it? And the others were more quantitative and they wanted to know like what portions of the of this consult were being taken up by the doctor speaking versus the patient or the support people speaking. So we did that on one side. So that's why I say it was very mixed methods. We had a lot of different things going. And what we decided to do was a purposive sample, subsample of these 264 to get a diverse sample of patients to speak to after the consult. So the way we prepared for that, well, I did all these interviews. We did a group analysis process, but the way I prepared for that was to listen to the audio recording, to read the transcript, to take notes, and see what are the areas where even with qualitative, you you have this, you have all of this rich data from the recording, but you want to ask, what was she thinking? What was he? Why did he say that? And so I had all of this ready. We had, of course, a well-crafted interview guide, but those core questions were supplemented by tailored questions for each patient based on what went on in there. So you were interested in why we chose individual interviews. It was really the only way to go. I mean, it would be interesting, I suppose, to hear a focus group of people talking about, oh, my consult did this and my consult did that. But you also have to figure that the participants were very ill. They were all over the country. We weren't doing online focus groups at that time. So that wasn't an option to even think about. And we really wanted the deep story. We wanted to know how these 20 individuals experienced not just the overall gestalt of the 2-hour consult, but different parts of it. So I was able to play back pieces of the interview saying, let me let's listen to this together a couple of minutes. And then I would say, I hear on the recording that you gasp. What were you thinking
So that
when
was actually from the visit with their second opinion doctor that you had
yes,
that audio that you were
exactly. I
using to
played
prompt
back pieces.
them. Mm-hmm.
Mhm. And sometimes I did that. And sometimes they said to me, can you find that piece about a half an hour in when he said this to me? Let's hear that, and I want to comment on it. So it went both ways, and then sometimes I just used I didn't play it, but I read maybe a snippet because it was a little bit quicker to find that. But that, like, what a chance to be able to say, what were you thinking? So it's more even than an exit interview because I had time to really analyze and digest the interviews. Interestingly, we only did 20, but subsequently part of our team did regular in-depth qualitative analysis of all 264 of those transcripts. So
Wow.
this was a large NIH funded study that had all these different components. I, what this allowed us to do was listen to the recordings and say, wow, 20 minutes have gone by and the patient hasn't said anything. The doctor is just talking and talking and talking. So I was, able to say things like, so, for the first 20 minutes or so, what were you thinking while the doctor was telling you all of this? And we were able to really learn what they were taking away, what they understood, what they didn't understand, what aggravated them, what they liked, and why. So,
So these
yeah.
were you conducted 2-hour telephone interviews.
Yes. And this was the first time I ever did interviews by phone. I'm an anthropologist. That is the last thing that ever crossed my mind that would be doable. But I have to tell you, it was a good thing to do for this topic because as I said, the patients were very ill, so they were home, they were comfortable. We were able to take a break. They were able to tell me, let me get a cup of tea, call me back in 15 minutes. And so we did that and we continued. Um, to be honest, I had been doing mostly prevention research in cancer. And this was a whole different thing, talking to people who were so ill, and so they didn't see my face. I was able to manage my own tissue box, while I was doing these interviews. It was really very intense. And we were able to include people uh, that really made up a good purpose of sample to get people of different ages and at different stages and males and females and um, living in different places and different ethnicities. So, yeah.
So that purposive is a word that I know I understand, but we haven't covered that yet in the course. So maybe talk a little bit about what you mean by a purposive sample.
Yeah, it's interesting. One thing that I like about qualitative research is the language. It's basically it is what it says, in the sense that you are not taking a random sample. You're not trying to do something numerically uh, sophisticated to say, oh, every third person. Well, that's not sophisticated, but every third person or some kind of random way of getting a power calculation. And some of your students might know a lot more about quantitative research. So the idea is that there's no point in doing these in-depth, time-consuming interviews that are a burden on the participants to spend this kind of time unless you're going to allow them to really speak their mind and that you'll get rich interviews. There's no point in talking to someone who doesn't have that much to say. There's no point in talking to someone who doesn't fit in your eligibility criteria very well. And we wanted to it wasn't huge. 20 is a good number for qualitative, but it's not huge compared to the 264 that we had in available to us.
Sure.
But given how intensive this was and how much time it took, this was a good amount for this study. And we wanted to make sure that we heard from people with different demographic characteristics. And so we purposefully looked at our sample and the demographics of, everybody whose recordings we had. And we thought, okay, so let's get a certain number of women, a certain number of men, a certain number of people at these different stages and living in different places, different ethnicities. I will say everybody spoke English for this study, but you could do it any way that you want. What you want is, what we like to say in anthropology is you want rich cases because there is no point in talking to people that won't produce that. So that's what we were looking for. Quantitative people sometimes say, "Oh, is that biased?" But it's too subjective. But it isn't if you can rationalize it and document what you're doing. Like this is the reason why we're doing this. This is why we didn't talk to people who spoke French. Like, what would be the point of talking to one person who spoke French, right? Because you can't put that into a sample where 19 people are speaking English, then that person would be, wow, that's a different category. You need to speak to more than one person in any category. So we were able to choose people with different demographics that we wanted to include so that we could hear the voices from all over. And that's what purposive means, really, that you sometimes they say purposeful. So you purposefully or purposively choose people that will be rich cases with the demographics you're looking for.
So you had 20. You did 2-hour interviews. How did you know when you had enough data? When did you know that, this was enough? You could sort of work toward figuring out what's going on here.
Yeah, that's a good question. 20 is a nice round number. And to be honest, I don't remember if we were aiming for 20 or because what you're aiming for, which I know you're getting at, is data saturation. So you want to interview people until you're basically not getting new data on new topics and new directions. Some people say new themes, but I feel like you don't really know until you look at all the data together what your themes are, but you know what the content is. You know that people are talking about different things. And so that's one of the reasons why we wanted to have um, kind of a, I guess you could call this one a heterogeneous sample. So it was homogeneous in the sense that everybody had to have um, hematological and oncological cancers, um, but they didn't. But we wanted a variety of other characteristics. So we we just did here's a word, iterative. So what we did was we analyzed iteratively, where we used a method which has come to be called immersion crystallization, but you don't have to worry about that. It really means read your data. Read it, think about it, take notes on it, discuss it with your team, read it again. And you just keep doing that as the data comes in and you see what's the content. And we started seeing that people had different opinions, certainly, but there were a lot of patterns that we just kept hearing over and over and over again. And so we also didn't want to overdo it because this was a lot of work for the participants, particularly. It's always a burden on participants to some extent, but such long interviews with people who are so ill. We didn't want to interview more people than we had to because it didn't seem ethically right. So we felt that we had learned a lot, and we had learned enough, at least for then. So.
What sort of cancers did this group have?
Well, these were blood cancers. It was a variety of blood cancers is what people had. So that was the other, you're right about that, that I didn't mention before, that was another demographic that we were including, people who had various different kinds of cancer. And I've been mentioning at different stages, but most people were quite ill. And that's why one of the interesting things was to interview the physicians and hear what they thought the prognosis was. And this was the hardest question of the interview. And I waited until way late in the interview to very kind of tentatively ask them what what they knew about their prognosis, what they thought. And to a person, they thought their prognoses were much, much better than their physicians had told us.
Oh,
So this is where I'm talking about having the tissue box, on the side where they can't see that because this is the kind of data that we started seeing over and over and over again. Yeah.
that's
Another
rough.
really interesting thing is, um, if, uh, if I could talk about in the results, you summarize what you're seeing on any particular topic, and you could see that in the paper with the subheadings. And then and you give quotes as evidence to illustrate your summary points. And it's in the discussion that you get to really talk about, well, what are the implications of this? And you can muse about that because you don't know for sure what the implications are. But in this situation, we thought it was really interesting because all of the physicians used a good 20, sometimes 30 minutes to just talk and talk and talk and talk to the patients and their support people in the beginning, and often would go on and on about this is this is a treatment that we often use, and they talk and describe the treatment and they say, but you're not eligible for that treatment. And then they go on to something else and they talk about that one and they say, but this one's not right for you. And I'm thinking, in my lay mind, wow, I wonder what that feels like. So I was able to ask the patient, so when the doctor was talking at length about all of this, what were you thinking? And it was very interesting when you talk about how did I know when there was enough data. Almost all the patients were saying, well, we realized that the doctor since we had come very far for this consult, and this was, an important second opinion consult, that the doctor was laying out his credentials. And I said, well, did it bother you? I mean, did you have any idea that you were going to get 2 hours? Because if the doctor takes half an hour, in most medical appointments, you wouldn't get a chance to ask anything. And
Right.
none of them knew that they were going to get 2 hours, but none of them were concerned about the length of time the doctor took. So here in the discussion section, the PI and I decided, yeah, but is that the best way to use the time? even if the patients don't mind, even if the doctors want to do it. So we did actually put in the discussion as recommendations that there might be other ways to use some of that first half hour that brings the patient in. Because we went into this study with a bias. Our bias was for patient-centered care,
Right.
and we were not seeing patient-centered care in these specialty consults. So it was it was interesting. So it's a fun part of the discussion section of a qualitative paper where you get to really try to think about and make suggestions for what could this mean for practice or what could this mean for policy. So
It seems to me you wouldn't be able to get that kind of rich information from a patient about their experience like any other way, like from a survey or from from some kind of instrument that you administer to them. It seems like there's really no other way to get down to the real personal experiences that people have without using this qualitative approach.
yeah, that's exactly what it is because you don't really want to even bother to use qualitative unless what you're looking for is meaning, text, explanation, the whys and the hows, the whats you could get from a survey. And you're better off getting it from the survey. But thinking about like we could have administered a survey, and we did actually, because the pre and post consultation interviews, not the ones that I did, but the ones that the staff did that were only about 5 minutes long, were all closed-ended with one open-ended question. And then we also did some analysis of those open-ended questions as well, so that I was prepared for, what I could be known that this patient was thinking at least at one time. So we that's what we wanted to know. And that's what you would want to know. So it seems like I think it's human nature for people to write closed-ended questions. The first time people set out to write questions, even if they know it's going to be for a qualitative interview, if you look at that question set later, even my own sometimes, you'll see, wow, a lot of these are closed-ended. And so what we mean by open and closed-ended is, do you, do, did you have concerns when you went into the second opinion consult? Well, that's a yes or no answer. That's a closed-ended question. So instead it would be, what were you thinking about when you went into? You could say, what were your concerns? Some people don't like that because it sounds like maybe it's leading that they had concerns, but they didn't. I don't worry too much about that because I feel like if someone didn't have any concerns, they're not going to make some up on the spot. So they might say, oh, no, I didn't have any concerns. But I like to ask questions like, okay, so you were, in the taxi going from your hotel to the hospital. What were you thinking? Or maybe I knew that they went there with their adult daughter. What were you and your daughter talking about? What were you thinking? What did you have in your mind? And you can ask it, and you ask it. The tone, I think, matters. So, and that's one of the reasons why I was also listening to the recordings as well as reading the transcript, because these were very emotional interviews, and you could hear in the recording things that someone who wasn't there during the interview would never imagine were actually in the interview because, you look at a transcript and it's flat. So that was the other thing in fact, we could have done this without transcripts. We could have done it straight from the recordings because the recordings were so important
So you're
to
talking about the recordings of the interview, the visit between the patient and those recordings.
yeah. So I had the recording of the 2-hour visit, and then we got transcripts of the recording. And then you're right. So then for
So for
for
the
the
interviews that
analysis,
you conducted, you needed transcripts for that,
yeah.
right?
Although I'll tell you, I've also done interviews that for one reason or another we couldn't get transcripts, and so we wrote papers and did the analysis straight from the recordings. But these, when you figure, these were 2-hour interviews, so the transcripts were probably 50 pages long,
Sure.
I would say.
Yeah.
So even just 20 interviews, that's a lot of pages. And so you definitely wanted, we definitely wanted to have written transcripts from that. But sometimes we went back to the interview too, because it looked so flat. We went back to the recording of the interview. I know there's so many parts to this study that it's a fun one to talk about. And I'm sorry if it's I'm going back and forth here, but for the analysis, we use the recordings of my interviews as well as the transcripts in order to really get a full sense of what people were saying.
Exactly. So if you were gonna do this all over again, would you do anything differently and why?
That's interesting. Um, not this study. I don't think I would do it differently. I will say we used a very easy to learn, open source, free coding software, which is no longer supported. Um, so I guess, it would be a good idea to use, some software that's going to stick around for a while.
Yeah.
But it's an interesting thing. I don't think I would do anything differently because we had quite a large team. We had several oncologists, several communication specialists, several kind of uh, technology communication specialists, anthropologists. We all were able to, quite a few papers were written from this study because there were so many different angles. So what you want to do is you don't want to collect so much data that you're not going to use it. And there's a tendency to do that. And it looks like when you look at our research design, you could say there's no way they used all that data, but we did. But those were the days of, 5-year NIH NC funded studies.
And the NCI is the National Cancer Institute is NCI,
Yeah.
and NIH is the National Institutes of Health, just in case folks aren't familiar with that. But that's, yeah, those are like major funding sources. Of course, right now it's things are a little crazy with the funding for scientific research, but do you know how much that grant was for? How many millions did you say?
I don't remember. I
Yeah,
can't tell you how
but
much that was for, but it was well funded.
yeah.
And, none of us were on the project full time, but we were able to get together weekly to really do a good analysis. And I know that the PI went on to do. Uh, she We were at Harvard. She switched to someplace else afterwards, but she went on to continue doing this kind of work to really ensure that her field and her surgeon colleagues, understand the patient perspective. So I think it was, in a lot of ways, it was experimental because a lot of what we did, we hadn't done before and others hadn't done before in terms of the methods. But I think it was really worth it. I feel good about the NIH expenditure for this particular study because a lot came out of it, that went right
Mhm.
into practice and policy.
It's nice to make a difference, right? So, if you were going to give advice to someone who is brand new to qualitative research, what kind of advice would you give to them? They're thinking about doing a qualitative project. Where do they start thinking? What would you say?
Yeah. Well, don't emulate this study because this really is a study that can only be done with a lot of time and a lot of people power and a lot of investment. But you have to think of a question that can be answered in an open-ended way. So for instance, my students, might be doing a study of decision making among young families around snack choices, or something like that. And so the research question, you have to start with your research question. So do young families in this neighborhood in Jamaica Plain section of Boston read snack labels in the supermarket. So that's not a qualitative question.
No.
If that's what you want to know, then do a survey. Um, but, you know, how do young families in this section of Jamaica Plain make choices around snack foods for their kids? So, what you want is an open ended question that would allow you to understand how people think about the snack choices that they're making for their children. So, how do people make the choices? So, that gives you such an uh, open playing ground where you can talk to them about what they're reading, who they're talking to, where they get their information from, what's important to their kids, what's important to them, why is it important, how does that play out when they go to the store, how, cost and availability and cranky kids and whatever it is, what their days are like, when they need to give snacks to their kids. Like all of this is really important to really understand how they're doing it. Labels might be part of it. You could ask about labels, but just thinking, oh, if people only read labels, then they would make better choices. And then just asking them if they read labels, reporting 64% of the people say they don't read labels. Well, what are you going to do with that? So you don't know. Why don't they read labels? Why, what else are they doing instead of reading labels? It doesn't mean they don't know anything about the nutrition if they're not reading labels. Maybe they're looking on the internet. So you want to understand like you've got the question, but then you want to almost like surround the question, surround the topic with all of this important context that allows you to really understand. And then let's say you want to make recommendations for policy or make recommendations for parent education in clinics. You know what people are saying and you know why they're saying it, or at least why they're thinking it. And so that helps you make recommendations that could be much more relevant than if you only know what's happening and then you think, but I don't know why it's happening. So this way, you can find out why it's happening.
Perfect. Well, thank you so very much for spending time with me today. And this was a wonderful conversation, and I really appreciate all of your experiences and expertise. And it's so wonderful to talk with you.
Oh, well, thank you for inviting me. It was great to talk with you.
Thank you.